recommendations. Also, in other certain circumstances, we can have this levatinib pembrolizumab combination came from keynote 775. Then pembrolizumab in high tumor burden tumors, where tumor mutational burden high tumors, which is coming from again keynote 15A. Then this Garnet trial showing dorstalimab monotherapy in recurrent cancers. Also other trials here such as EAY131 showing nivolumab, then Destiny trial showing trastuzumab combination. So all these recommendations, but how to remember all these trials? So today we will try to classify them. So this is immunotherapy trials in endometrial carcinoma, which we can divide into monotherapy trials and combination therapy trials. So monotherapy means single agent immunogenic drug, which we are using. The research started from this area. So first all the research started in recurrent cancer and then it comes into the upfront therapy. So first we had these basket trials having multi-cohort trials. Out of all the cancers, one cohort will be endometrial carcinoma. So in keynote 158, we have this cohort D and K, which is regarding endometrial carcinoma, and they use pembrolizumab monotherapy. And in Garnet trial, which is again a basket trial, in cohort 1, A1 and A2, they use dorstalimab. Now coming to the next the combination therapy trial. So in this we have first in the previously treated endometrial carcinoma.
Mansi, can you tell us what is basket trial? I mean, a little bit when you were saying. So can you little bit? You were right when you said that, but then can you little bit explore what is a basket trial for here for them to understand, because you will literally written that multi-cohort trials. Yeah.
So ma'am, along with endometrial carcinoma, these trials were including other solid tumors also. So
the solid tumors having MMR problem.
Having MMR deficiency. Yeah, because this is immunotherapy, so we are concentrating on specific target. So here they were concentrating on this target, which is seen mostly in MMR deficient tumors, and MMRD can be seen in many solid tumors.
So here you have to understand that whenever you are doing trials with immunotherapy or drugs like that, so and then when we are specifically targeting tumors, as she has very clearly said that only very few tumors will meet the criteria. I mean, they should be advanced, recurrent, metastatic, or they should be having good performance status, should be able to tolerate the disease, tolerate the drugs, and also should have MMR status. So very few tumors will be like that. So to have the exact effect of these drugs, they would include multiple sites with same target. So this is the definition of basket trial. So these trials are important for having investigation done for a rare, I mean, kind of less commonly seen condition. So these all trials that we study, they are usually basket trials, as she has very nicely mentioned here. Okay, Mansi, please go ahead.
Yes, ma'am. So we'll just in short see the what benefit we got from this monotherapy trials. So in keynote 158, in the endometrial carcinoma cohort, we could see the ORR, that is objective response rate benefit, being 48, and in the specifically MSI high endometrial carcinoma, and in other trial, which is Garnet trial, we could see it as 46% in dMMR group. Whereas in MMR proficient group, we saw less benefit, but still it is clinically beneficial in 19%. So after this, we have this, based on this Garnet trial, the FDA approval came up that dostarlimab was approved in European Union for dMMR, MSI high, advanced or recurrent endometrial cancer, and in United States for dMMR advanced solid tumors. After this came the keynote 775. Here there is combination of levatinib plus pembrolizumab. So this is how the chart goes, that levatinib 20 mg per oral and pembrolizumab 200 mg IV 3 weekly. was one group, and other group received physician choice chemotherapy, such as doxorubicin or paclitaxel. And here the primary key points were PFS, that is progression-free survival, and secondary key points were objective response rate and others. Now,
these were the patients who had already received first-line chemotherapy, TP? Because
yes, ma'am.
So this is important for us to understand that this particular group investigated those patients who were already received first-line chemotherapy, and for them they wanted to give monotherapy. I mean single agent immunotherapy, right?
Yes.
And that is why in the control arm they are not giving TP, they are giving doxo or pacli single agent, है ना?
Yes, ma'am. As here we can see, previous platinum-based chemotherapy was given to them. After that, So after this, this is the graph showing the objective response rate in MMR patients were 32.4. So they showed the benefit in MMR proficient patients also. After this trial, now there are ongoing trials in monotherapy. Keynote C93, which is again using pembrolizumab, and Dominica trial, which is using dostarlimab. But now this is they are trying it treatment-naive advanced endometrial carcinoma. So as Madam just now said, the previous trials are in carcinoma where already one line of chemotherapy has been given. But now we are trying immunotherapy in treatment-naive endometrial carcinoma. So today we will be concentrating on this particular subgroup, which is a combination with cytotoxic chemotherapy. And we have 4 trials in last year only, which were published. So Ruby trial, NRG GY 018 trial, DOE trial, and ATTENT trial. So out of this, Ruby is using dostarlimab, NRG is using pembrolizumab, DOE using durvalumab, and ATTENT using atezolizumab. So all these PD-1 or PD-L1 targets. Coming to the basic of combination chemotherapy. So when we were using monotherapy and they were showing good clinical benefit, then why we moved to combination chemotherapy? That we will see now. So what was happening when we were using single agent immunotherapy? It was showing limited response in endometrial cancer because in some tumors such as melanoma, renal cell carcinoma, immunotherapy has largely replaced the chemotherapy owing to the clinical benefits and toxic profile. And generally, they are more manageable, less severe than chemotherapy and radiotherapy. But what happened is response to this immune checkpoint blockade monotherapy is usually around 20% across the solid tumors. Why this is happening 20% only? Because of primary and acquired resistance to immune checkpoint inhibitors. So there is need to further investigate in this aspect, that identification of novel biomarkers to discriminate the best responders out of this whole chunk of solid tumors, and the combination immune checkpoint inhibitors with other therapeutic modalities are promising avenues to improve their clinical response and patient outcomes. Now, what is the rationale of chemo and immunotherapy together? Now, immunotherapy has the capability to eliminate disseminated and metastatic cancer, while it is less effective in eradicating a solid tumor mass. Chemotherapy may potentiate the efficacy by ability to debulk the solid tumor mass and thus decreasing the number of cells that should therefore need to be eliminated by the immune cells. And cytotoxic chemotherapy can also produce immunomodulatory effects. Thus, combination of chemotherapy and immunotherapy may have synergistic effects in the tumor microenvironment. Clinical benefits, including improved survival, have been reported with this combination in several cancer types. This is the synergistic effect that we can see. So, common chemotherapeutic drugs may induce anti-tumor immunity mainly through they activate the effector T cells and natural killer cells, and by specifically dampening the immunosuppressive tumor microenvironment. This happens in a dose and schedule dependent manner. Hence, further trials are needed to decide one particular dose of immunotherapy when it is given along with chemotherapy, and what should be the schedule, like how many years we have to give, what we like 3 weekly, 6 weekly, how we should give it. Now, in this diagram, we can see that here paclitaxel is helping to like targeting the immunosuppressive cells. Then here we can see again here docetaxel is, and then cisplatin is enhanced immune cell infiltration. Then cisplatin again increase antigen presentation by dendritic cells. So this is how it is helping us. Then immunogenic effects, if we go in further details, we can see that it inhibits the myeloid-derived suppressor cells. Then immunogenic cell, after immunogenic cell death, it increases the antigen cross presentation, and also an increased ratio of cytotoxic lymphocytes to regulatory T cells. So in this diagram, we can see how the along with chemotherapy or other mechanisms such as radiotherapy or anti-VEGF, those drugs, those also help each other and bring synergistic effect by releasing the neoantigens, or by how T cell infiltration and trafficking they are increasing, down regulation of PD-L1 expression they are doing. So all these complex mechanisms are helping us for the synergistic effect, and thus combination therapy is needed to increase the benefit.
Just go back.
Yes, ma'am. Yes, ma'am.
One question: what is this abscopal effect you've written? Can you explain?
So in radiotherapy, abscopal effect. It basically kills the cells, the tumor cells, and thus there is release of these neoantigens. Am I correct, ma'am?
Yeah, that's fine. But then what happens is abscopal effect is, I think, related to that when the tumor is dying there, that will release those antigens and all those things, and then there is an immunomodulation which happens at the metastatic sites, and these sites are also killed along with primary tumor. So this is how it helps. You know, the immunomodulation happens this way.
Yes, sir. Even metastatic sites also will die, because we are giving radiotherapy only to the particular area, but metastatic sites also will reduce the tumor burden. That is abscopal effect. Yes, sir. Then coming to the MMR status importance. So why this MMR deficiency is important? Microsatellite instability high tumors account for 25 to 30% of the endometrial cancer. So as we can see in this diagram, other cancers are also showing some percentage where they are dMMR, but out of that, most effect is shown, mostly the percentage is high is in the endometrial carcinoma. Also, our cancer genome atlas network also found that 28% of the endometrial cancers had high microsatellite instability. Now coming to the increased expression of PD-1 receptor and its ligands, that is PD-L1 and PD-L2, and high tumor mutational burden is associated with MMRD and MSH high tumor. So this is how we are concentrating on this MMRD type of endometrial carcinomas. This makes them potentially susceptible to anti-PD-1 or anti-PD-L1 therapies. Now we will try and focus on RUBY trial. RUBY was a part of international collaboration between European Network of Gynecological Oncology Trial Groups, that is ENGOT, that is a research network of European Society of Gynecological Oncology, and also GOG Foundation, which is a non-profit organization. So this RUBY trial was done in two parts. Part 1 part 1 has active comparator as dostarlimab plus carboplatin paclitaxel combination, followed by dostarlimab maintenance therapy. And placebo comparator is here. And in part 2, they have used in a combination in the maintenance part the combination of dostarlimab plus niraparib. So today we will be focusing on this part 1 of the RUBY trial. So it is a phase 3 randomized double-blind multi-center study Recruitment was done from 2019 to 2021. It was done in 3 sites in 19 countries. And what is the background of this combination therapy? Why it was needed this trial? Because approximately 15 to 20% of the women in endometrial cancer will be diagnosed in advanced stage at the time of diagnosis only. But their long-term outcomes remain poor, and overall survival in advanced and metastatic carcinoma is less than 3 years. SEER database show that 5 years relative survival rate for localized endometrial carcinoma of 95%, but whereas in metastatic stage, it is only 17.3%. Now, carboplatin plus paclitaxel is a standard therapy for so many years, but survival of the woman in uterine cancer has not improved during the past 4 decades. Hence, the new treatment options are urgently needed to evolve the current standard of care. So, in Ruby trial, the eligibility criteria was histologically or cytologically confirmed primary, advanced, or recurrence endometrial carcinomas, stage 3 or 4 endometrial cancer that was not amenable to curative therapy. Then ECOG performance status of the patient 0 or 1, and adequate organ function. Now, when we go in details of this eligibility criteria, we understand that in primary stage, if the patient is having stage 3A, 3B, or 3C1 disease, it should be measurable according to RECIST 1.1 criteria. If it is primary stage 3C1 disease with other histologies, that is high risk histologies such as carcinosarcoma, clear cell, serous, or mixed histologies, then it is regardless whether it will be measurable or not measurable. Also, C3C2 or stage 4 disease also, even if it is not measurable, it is okay to include in this trial. Next criteria is disease that was in its first recurrence and had not been treated with systemic therapy. Also, had been treated with neoadjuvant or adjuvant systemic therapy and had recurred or progressed at least 6 months after the completion of the first treatment. That is, the interval between chemo and the recurrence is at least 6 months. And this whole group was stratified into subgroups accordingly. MMR, MSI status, whether they are MMRD or MMRP, then prior EBRT was received or not, and next stratification was according to disease status, whether it is recurrent, primary stage 3 or primary stage 4. This is the whole trial represented in one slide. We'll see slowly one by one. Now, after this eligibility we have seen and stratification we have seen, this was divided into 1:1 randomization, this 470 patients, and first group was given dostarlimab 500 mg plus carboplatin AUC under AUC 5 and paclitaxel 175 mg per meter square. This is the normal chemotherapy combination and dose that we give for endometrial carcinoma. Along with that, dostarlimab 500 mg they have added. This chemotherapy is given 3 weekly for 6 cycles, and followed by dostarlimab 1000 mg 6 weekly for next 3 years, for a total 3 years. Then next group is where they have given C plus the carboplatin combination along with placebo, and followed by placebo 6 weekly for 3 years, and these patients were followed up. This therapy was continued for 3 years unless and until there was disease progression. Other reasons to stop the treatment were treatment discontinuation due to toxic effect or patient withdrawal or investigation decision to withdraw the patient or patient's death. Now coming to the assessment, so CT or MRI was done every 6 weekly from the randomization until week 25, followed by every 9 weekly until week 52, and subsequent imaging was every 12 weekly until radiographical progressive disease, and after that also there was one more additional imaging assessment done 4 to 6 weeks later. And this whole group they followed for median follow-up was 25.4 months. Now this is a diagram showing enrollment and randomization. Important points here are, so discontinuation for the trial treatment and their details. So 45 patients in dostarlimab group had adverse events. That's why they discontinued the treatment. Versus in placebo group, excuse me, in placebo group, 24% of the 24 patients had adverse events, and therefore discontinuation. Then in dostarlimab group, 107 patient had progressive disease versus, excuse me, in 160 patient had progressive disease in the placebo group. Now coming to the demographic and clinical characteristics of these patients. So important points to note here are disease status. So recurrent disease were seen in almost 50% of the patients, and rest 50% were stage 3 or stage 4 primary advanced patients. Now coming to the this histologic type. So almost 50%, 54.7% were endometrioid histology, and important thing is this trial has also included carcinosarcoma along with other histologies. Then pMMR status. So around 50% of the patients were pMMR MSI high, and rest of the patients, 20% of the patients were dMMR group, and the rest of the patients were MSI stable patients. So here we can see this is it is consistent with what we see generally in endometrial carcinoma. 25 to 30% of the patients will have this dMMR status. So in this trial, we had this 21.6%. Now these are the graphs showing. So they divided this whole population and into dMMR, pMMR, and also overall population. The 3 subgroups they have done for the analysis. So as we see here, in progression-free survival, we can see the hazard ratio being 0.28, and it is clinically significant. P-value is less than 0.001. Also, in MSI population, that is MMR proficient population, the hazard ratio is 0.76, and it is also showing benefit. But as we see in this graph, this benefit is more than this benefit, substantially high in MMR D subgroup. Overall population also shows the clinical benefit, p-value being significant. After this, we will see the overall survival. So overall survival also has the hazard ratio 0.3, and it is also showing clinically significant benefit in MMR-D subgroup as well as MMR-P subgroup. But MMR-D is showing more benefit than MMR-P. And in overall population also, overall survival is with 25.4 months of follow-up. Overall survival was longer with dostarlimab regimen than the placebo regimen. Also hazard ratio being 0.64. But though the p-value was less than 0.05 that we are considering normally as the standard, but they some statistical analysis they have shown in the trial, and they are saying that these results did not reach the level of significance that was established as the stopping rule, where the stopping boundary for p-value was much higher than the observed value. Coming to the next, that is safety profile, that is secondary outcome. In most common adverse events in both the groups were fatigue, alopecia, and nausea. But these are seen in both dostarlimab as well as placebo group. So, and with the same frequency. As we can see here, fatigue, alopecia, nausea, almost 50% in both the groups. When we think about what side effects were specific to the dostarlimab group, then we can see the immunogenic effects such as rash. So rash here is seen significantly 22% of the patients in dostarlimab versus only 13.8% in placebo group. So this may be one of the side effects that is particular to dostarlimab and not to the general chemotherapy, cytotoxic chemotherapy. Coming to the next, the incidences of grade 3 or higher adverse events and serious adverse events that occurred and worsened during treatment were each approximately 10% points higher in dostarlimab group than in placebo group. So here we can see the adverse event 70% versus almost 60%, and serious adverse event 37.8 versus 27.6.
Your voice
so
is 10%. Mansi, your voice is.
Okay, ma'am.
Thoda
is it audible now?
Position?
Yes, ma'am. Is it audible now, ma'am? Yeah. So here we can see 10% higher grade 3 or higher adverse events in the dostarlimab group than the chemotherapy. Than the placebo group. And then coming most common adverse event leading to discontinuation were maculopapular rash in dostarlimab group.
Mansi, can you go back to the previous slide? Just can you go back to the previous slide?
Yes, ma'am.
Just yeah. So what they wanted to say was that if the significance between the two groups of these adverse events was considered significant when the difference was more than 10 percentage points in each group in the two groups, is that so? And then they are saying that yes, one group was 60% and one was 70.5%, so there was significant difference. Is that so?
No, ma'am. When in the discussion point, in the discussion they are saying that though this is like 10% change, but what other trials we have seen in immunotherapy, they also have this much difference, and it is consistent with the other trials. So this much is acceptable. That's what they are saying.
Okay.
So when we are giving this combination
TP will also have, okay, as such, because in the control group they're already giving one toxic chemotherapy to the patients, so we expect that some side effects will be there. So till 10% it was acceptable as per other trials. If it was more than that, then they would give us significance, and the difference we can see is 10%. Is that so?
Yes, ma'am. Like they are saying this is acceptable because as we are adding one more drug, there is bound to have some more side effects because of that immunotherapy. But
your voice
it
is again
still managed. Oh, sorry. It is again manageable and acceptable. That's what they are saying in the discussion part. So after this slide,
any specific adverse event?
This is maculopapular rash, ma'am, and which is seen in dostarlimab group. As we can see here, the immune-related adverse side effects were hypothyroidism, rash, arthralgia, and in
voice is breaking very badly.
Okay, sorry, ma'am. Listen. Is it coming now, ma'am? Hello?
Not so good. It started becoming a little better. Let's try.
So, ma'am, this immune-related adverse events, they are saying that most commonly are hypothyroidism, rash, arthralgia, and increasing alanine aminotransferase levels. These are immune-related adverse events occurred in this trial. Hello? Am I audible?
Go ahead. Yeah, go ahead, please.
Okay. Then mortality details. So one death was related to the dostarlimab group and occurred during 90-day safety follow-up, which was due to hypovolemic shock. And other 3 deaths were not judged not to be related to the dostarlimab regimen, which is opiate overdose or coronavirus pandemic. Due to that, the patient was dead, and a general deterioration of physical health. So along in 470 patients, they saw these many deaths. And this is also a plus point of this trial, that they have given the details of the mortality. Coming to the discussion, significantly lower risk of progression or death was seen in this trial. So 70% lower risk in DMMR population and 36% lower risk in overall population. And second important point, as I already told, the carcinosarcomas were eligible in this trial. Then tumors that are MMR proficient generally have a reduced tumor mutational burden, but PD-1 expression is prevalent in this type of endometrial cancer also. So thus we can still use the immunotherapy in MMR proficient tumors also. And by using those chemotherapy, PD-1 expression is more, so we can target this PD-1 instead of PD-L1. Then approximately 3/4 of the population in this trial had MMR proficient disease, which is consistent with, as we have seen, 25 to 30% is DMMR. So rest of the patients are PMMR, which is consistent. Now coming to the low, so they saw the progression-free survival in placebo group was lower than that seen in the GOG 209 trial, where they have decided carboplatin plus paclitaxel as the standard chemotherapy. So what is the reason why in placebo group also progression-free survival less than the previous trial? So reason they are giving is stage 3 disease or non-measurable 3 to 4 stage 3 to 4 disease in that trial was lesser than what we are including in current trial. So in current trial there was higher percentage of the recurrent disease than the previous trial. And this can be the reason why overall PFS is low even in the placebo group. Other trials are showing consistent result, but they said that it is difficult to compare with the trials because of the heterogeneity. Now coming to this next forest plot, where we can see all the hazard ratios are showing benefit, but only here one like primary stage 3 disease is showing less benefit. The reason behind it, they are given that extended follow-up may be necessary in order to observe a treatment effect in the subgroup of patients with stage 3 disease because of the limited sample size and relatively short follow-up period. So since the sample size is less and short, follow-up period is also short, maybe we need further follow-up in this regard to say whether it is actually having benefit in stage 3 primary disease or not. Coming to the safety profile, so this safety profile, as we discussed, it was consistent with that of the individual component of the regimen, and frequency of discontinuation of chemotherapy was similar in both the groups. So though the 10% higher was seen in dostarlimab, the frequency for discontinuation was the same only in both the groups, and the quality of life was also similar in both the groups. So this is how they are defending that it's acceptable to have this much toxicity in our trial group. After this, then coming to the conclusion, Ruby phase 3 trial met its primary endpoint and it showed substantial benefit in dMMR MSI high tumors. And Ruby is the only first trial to show improvement in progression-free survival for an immuno-oncology therapy in combination with standard of care chemotherapy in primary advanced or recurrent endometrial cancer. So after this, we will compare this Ruby trial with other similar trials, which are combination therapy trials. So here we can see first trial, which is NRG GY018. This is also published in 2023. Similar eligibility criteria were there, and they gave this pembrolizumab 200 mg IV every 3 weekly along with carboplatin paclitaxel chemotherapy, followed by pembrolizumab 400 mg every 6 weekly for additional 14 cycles. And versus placebo group was there. And primary endpoint again PFS. We will see comparison of these 4 trials in the next slides. And then next trial is DUO-E trial. This DUO-E trial has 3 groups. So similar again eligibility criteria. Again stratification is also similar to the Ruby trial, and 3 groups were randomized as 1:1:1. Control, durvalumab group, and durvalumab plus olaparib group. So here they have added one PARP inhibitor also along with the standard chemotherapy plus immunotherapy plus PARP therapy, like three together in this one. So as we see in control group chemotherapy, then in this combination group, they have given paclitaxel carboplatin 3 weekly plus durvalumab 1120 mg IV every 3 weekly. This is the starting that 6 cycles that we give. After that, in maintenance part, they have added this durvalumab 1500 mg every 4 weekly plus olaparib 300 mg tablets twice a day. So after knowing this basic of these 2 trials, recently one abstract is published of this ATTEND trial, which is using atezolizumab as a immunotherapy drug, and the study design is like in control group again same chemotherapy followed by placebo, and in this group they are giving C plus 3 along with atezolizumab 1200 mg followed by same dose maintenance of atezolizumab. So as we saw these other 3 trials and what dosage they are giving, now let us compare these 4 trials. And this is done in this recently published meta-analysis where they are saying that efficacy of immune checkpoint inhibitors combined with cytotoxic chemotherapy in advanced or recurrent endometrial cancer, and a systematic review and meta-analysis. This is published recently, 24th May 2024, which included 4 trials. So the 4 trials which we just saw, RUBY, GY018, 2OE and ATTEND trial. Total 2,335 patients were included. The primary endpoint they considered was pooled hazard ratio, which was further analyzed across the subgroups, which were based on MMR status, race, then histology, and PD-L1 status. So let us see the details of this meta-analysis in short. Highlights of this study was this immunotherapy and platinum-based chemotherapy are primary options for advanced and recurrent endometrial carcinoma, which prolong the PFS and OS. And they saw that they concluded it with saying that substantial PFS benefit was observed in patients with Caucasian race, then endometrioid histology, and those having PD-L1 positivity. So we will see one by one all these 3, how they are saying that this is showing higher benefit in these kind of patients. So they concluded that personalized treatment are vital in this immunotherapy and considering factors like MMR status, ethnicity and PD-L1 expression. So slowly we are moving towards personalized treatment in all the areas, all the cancers. So in endometrial carcinoma advanced stage also we are moving towards it. Now here is the summary for all the 4 trials. So here, though it is a easy slide, we will see one by one important things. The trial name are given here, all 4 trials. What immunotherapy agent they are using. The median age is similar, that is around 65, 67 years of age. Then median follow-up is different. So here we see the ATTEND trial is a very good trial. It is showing 28.3 months follow-up. And whereas this GY018 trial, it has less follow-up, like 12 months for TMMR and 7.9 months for PMMR group. Then the patients, then coming to the proportion of the Caucasian in overall population, because they wanted to see the subgroup analysis of this ethnicity. What they found is 58.2%, that is less in DUO-E trial. Caucasian group is less as compared to the other trials. Now, what are the highlights of these trials? All are phase 3 double-blind placebo-controlled RCTs, whereas RUBY has how did they check this MMR status? So in RUBY trial, they did MMR as well as MSI status. Both the tests were done. But rest of the trials did only MMR status by immunohistochemistry. Central review was done, but only IHC central review was done. Then in GY018 trial, carcinosarcoma was excluded, and rest all the trials included carcinosarcoma. In DUO-E trial is the first trial which had this PARP addition into it. Other 3 trials are not showing it. But while comparing in this meta-analysis, they have excluded this PARP group because there are no comparisons in other trials, similar comparisons. And also that DUO-E trial is the first trial where they did PD-L1 expression subgroup analysis, also HRRM testing, which is genetic testing. These subgroups also they included. Other differences and other comparisons are, so Asian population, as we saw, then DUO-E trial had less Caucasian ethnicity involved. So why? Because they had more 28%, which is significantly more than the other trials as Asian population. It also included Indian investigators, and Indian population is also involved in DUO-E trial. Now, eligibility criteria, how they differ, all other criteria are similar except this chemo-free interval from the previous chemotherapy and recurrence. So, either 6 months in 2 trials and 12 months in 2 trials, this interval was. Now, coming to the data maturity, which is very important. So, higher the data maturity at the time of publishing the trial, better are the reliability of the results. So, DOE trial has very less as compared to other trials, the data maturity. So, we will be requiring further analysis and follow-up of this trial also. So, these are the PFS benefits seen in DMMR group that we are particularly focusing, and it is showing significant benefit in GY018 as well as RUBY trial. And adverse, coming to the adverse events, more than grade 3 or equal to grade 3, they are almost similar in the trials except GY018, and lower risk of progression or death, that is also significantly higher in DMMR, also seen in PMMR group in the trials. Now, after this, what about risk of bias assessment? So, this meta-analysis also done, this risk of bias, how much can be the bias in this trial, and they found every aspect there is low risk of bias. So, overall, these are good RCTs can be considered. Coming to the all-comers, this is a forest plot where they now started subgroup analysis. So, in Caucasian subgroups, all comers mean they, without dividing them into DMMR or PMMR, all the population of the study. They saw that, as we can see here, so in this all-comer population, non-Caucasian subgroup is not having any benefit versus Caucasian subgroup. So thus they concluded that Caucasian subgroup may be benefited more with the immunotherapy. Coming to the next subgroup analysis, in endometrioid cohort, so in DMMR group particularly, we can see here the benefit is more, and here the hazard ratio is not that significant. So what they are saying is, when DMMR patients, endometrioid histology than the other serous or other histologies, this kind of patients are showing more benefit. Then coming to this PD-L1 positive subgroup, here we can see again in the forest plot that is PD-L1 positive subgroup was associated with significant benefit of PFS compared to negative PD-L1 subgroup. Then coming next is PMMR anti-PD-1 cohort. Now, this is particularly very much detailed analysis where we can see in MMR proficient, that is the unmet need yet, because MMRD anyway showing higher benefit of immunotherapy, so we can anyways give but in MMRP not that much benefit is shown. So this is where we need to research more. So they found that anti-PD-1 and PD-1, that is like PD-L1 and PD-1, that is how they divided these groups, and they found this PMMR subgroup, they have anti-PD-1 cohort as showing the more benefit. So this is how in future we may, if the further trials prove this, we validate this, we can think that much that if the patient is having MMR proficient, we can try PD-1 therapy instead of PD-L1 therapy in them, and that will be more significant. Coming to the next, the proportion of MMR status by race and histology. So here we can see the Caucasian, the significance is showing in Caucasian in both the trials, RUBY and GY018, and proportion of DMMR was significantly higher among Caucasian in both the trials. Then non-endometrioid histologies, exploring potential targeted therapies beyond immunotherapy targeting PD-L1 and PD-1 might be imperative, because in non-endometrial histologies, as we see, they have not found that much benefit. So here they are saying more than immunotherapy by PD-1, PD-L1, other targets such as HER2, that is trastuzumab. These can be the novel biomarkers for serous histologies or non-endometrioid other histologies. Coming to the discussion, this analysis highlights the crucial role of molecular and demographic factors in modulating the responses to immune checkpoint inhibitors. In this study, the use of immune checkpoint inhibitors in the PMMR cohort did not statistically demonstrate a benefit in overall survival. However, considering the trend towards the overall survival benefits, observed in other clinical trials, further validation with mature data is warranted for the assessment of the overall outcomes. Limitations of this meta-analysis that they are telling that it included only the reported outcomes of these trials. They have not individualized, individual patient data was not pooled. Whatever reported by these trials, that only they have considered. So there can be a higher degree of selection bias. Then in ATTEND trial, they had only the abstract was available. Whole trial was not published at this time of this meta-analysis. So many data points were missing for this trial. And third limitations that they have told is the impact of overall survival was limited. So the further analysis is required when the data is matured. For this reason, they are saying that some caution is needed to interpret these results, and for future upcoming data is eagerly awaited. Coming to the future perspectives, so as we can see, the immunotherapy is now increasing and lot of trials are still ongoing in various aspects in endometrial carcinoma, in immunotherapy combinations. So maybe in future it will happen that, as we know now, DMMR type of subgroup, we are giving checkpoint inhibitors followed by maintenance of this same immunotherapy. In NSMP, they are trying with selinexor study or natinmanlin study, and in P53 mutated patients, they are trying with either checkpoint inhibitor or trastuzumab. As we said, HER2 can be the novel biomarker in those serous histologies. Thank you.
It was very nice, Mansi. Appreciated your presentation. It was really very extensive and very well done. Thank you, ma'am. And then now question is, how do you decide the biomarker to be tested for assessing the immunotherapy response?
Ma'am, can you please repeat the question? Actually, I'm not able to see this.
Sure, no problem. The question is, how do we decide on which biomarker to be tested to assess the immunotherapy response? No worries. You have already explained that in your presentation, Mansi. Very well, you've done that. See, MMR status is the most important biomarker to decide the mode of whether we should start immunotherapy or not. Whether to assess the immunotherapy response based on that, that will be, I think, clinical response, radiological or clinical response to the disease, and not based on any biomarker, as of my understanding. And another thing is that which biomarker, yes, we have three things which we usually, the trials have used. That is, one is MMR status, second is PD-1, PD-1 receptor status, and third is tumor mutational burden. So these are the three important biomarkers which are utilized for immunotherapy trials. But out of all these three MMR status is the most proficient one. With the endometrial cancers specifically, PD-1 status or PD-L1 status has not been found to be very effective for clinical utilization. So most of the trials have used MMR status, especially the upcoming ones. CPA score has been utilized. Yes, CPA score has been utilized more than 1%, and they found that especially in the Ruby trial, I think they have found the patients who had CPA score difference, they were like difference in the response was already there in those patients, so they have given based on that. So that's what I'm saying, tumor mutational burden or CPA score, these things are utilized. But then they have, I think I have read somewhere that MMR status and tumor mutational burden, these are the most important, especially in the endometrial cancer cases. These are the most important clinically used biomarkers. Anything else you want to add, Mansi, or we have other faculties if they want to add something onto this? Bhagya ma'am, ideal CPS score. Ma'am has asked what is ideal CPS score. Mansi, this you should answer.
So it is like as
first you explain
my understanding
CPS score. First you explain what is CPS score. How do you define CPS score? Can you explain that?
Now it will be difficult for me to tell it in detail. Can you please help me with
Not in detail. You don't need to tell in detail. Just simple. What is CPS score? So batao, what is that? Number of cells which are showing. Batao, it's a ratio, no?
So like positive tumor cells divided by total number of viable tumor cells. That much I know, ma'am, but into 100, like, but further I am not able to tell.
No, that's fine. You told it correctly. The number of tumor cells just showing positive tumor cells, all the cells in the body actually, tumor cells, lymphocytes, macrophages, just showing presence of PDL1 or PD1 staining versus all the viable tumor cells. This is a proportion of that is CPS score, and it is more than 1%. I think it is like kind of considered better. More immunotherapy is better. More immunoresponse will be there, right? So intermittently, it's like TK, it's fine. But I still say MMR status we have, especially in this particular tumor, which makes it more clear and easy for us to be utilized in clinical therapy. So if you're asked the question which biomarker, then MMR status, I would suggest that this should be the answer. Rupinder ma'am and Bhagya ma'am are now the panelists. Bhagya ma'am, Rupinder ma'am, comments from you, ma'am.
Yeah. So thank you so much, Mansi. It was really very exhaustive and very, I think you have explained everything so well. So if I understand correctly, that 1% CPS score is good, but if the CPS score is more than 20%, the response is much better.
Okay.
So if it is between 1 to 20%, you can give this your immunotherapy, but the response would be better if the CPS score is higher. So for endometrial cancer, 20% is a very good thing. So if that is there, then your response rates are going to be really high.
Yeah. Okay. So better the CPS score. This I think this subgroup analysis was done in your Ruby or Garnet trial also. They have clearly shown that they have used this particular score to substratify the patients in those trials.
Yeah, I think that's all. I think she has actually done a very good job.
Yes, yeah, same thing.